If you were the nurse for a patient going into surgery, what are the pre-op and post-op teachings you would discuss?
In my experience, one of the most important things for a successful surgery is making sure the patient feels informed and prepared. Especially when someone is anxious, taking the time to walk them through everything step by step using a structured approach can make a big difference. First, I start by understanding the situation. What kind of surgery are they having? What are their biggest concerns? Then, I can tailor my task, which is basically making sure they have all the information they need before and after the procedure. For pre-op, I'll explain things like why they can't eat or drink anything after midnight, to prevent aspiration during anesthesia. We'll also go over any medications they need to stop or continue taking beforehand. Sometimes, a preoperative shower with antibacterial soap is recommended to reduce the risk of infection. And of course, I'll let them know what time to arrive at the hospital, where to go, and what to bring with them. Once they've recovered, it's all about helping them manage their post-op care effectively. That means teaching them about pain management options, including medications and non-medicinal things like ice packs. I'll also go over how to care for their surgical site and what signs of infection to watch out for. We'll talk about any activity restrictions they might have and the importance of getting enough rest to heal properly. Finally, I make sure they understand the importance of follow-up appointments so we can monitor their recovery and address any concerns they might have. And of course, I'll educate them on any symptoms that would require them to seek immediate medical attention, like a fever, severe pain, or unusual bleeding. By empowering patients with knowledge about their surgery and recovery, they feel more confident and in control. This leads to a smoother overall experience, fewer complications, and a faster return to their normal lives. It's all about working together as a team for the best possible outcome.
If you were working on a floor and a doctor came up to you and yelled at you referring to the patient that wasn't yours and you had not been taken care of, how would you respond?
I haven't experienced a situation like this before, but if a doctor came up to me and yelled about a patient who wasn't mine and whom I hadn't been taking care of, I would handle the situation with professionalism and composure. First, I would remain calm and avoid reacting defensively. I would listen to the doctor's concerns without interrupting, allowing them to fully express their frustrations. Once they finished speaking, I would politely clarify the misunderstanding by stating, "I understand your concerns, doctor, but I believe there might be some confusion. This particular patient has not been under my care. However, I am more than willing to help you find the nurse responsible for this patient or assist you in any other way." By addressing the issue calmly and offering assistance, I aim to de-escalate the situation and facilitate a resolution. Additionally, after the immediate issue is resolved, I would follow up with the doctor privately to discuss the incident and ensure that future communications are more respectful and constructive. This approach not only helps maintain a positive working relationship but also ensures that patient care remains the primary focus.
If you were a nurse on a floor and you walked into a room and the patient was short of breath and said they were having trouble breathing, what would you access and why? If you hear wheezing and you note that the patient has a history of asthma, then what would you do? How would you chart this scenario?
As a nurse, discovering a patient who is short of breath and having difficulty breathing would immediately prompt me to assess their respiratory status and take swift actions to stabilize their condition. My primary focus would be on addressing the patient's immediate needs while ensuring their safety and comfort. Upon entering the room, my first priority would be to assess the patient's airway, breathing, and circulation, ABCs. This assessment is crucial for determining whether the patient's airway is clear or obstructed. I would closely observe their breathing pattern, checking the rate and depth, and listen for abnormal breath sounds like wheezing. Wheezing often indicates an obstructive issue, such as asthma, and can signal the need for immediate respiratory support. Additionally, I would assess for visible signs of respiratory distress, such as cyanosis, use of accessory muscles to breathe, and any alteration in the patient's level of consciousness. Given the patient's history of asthma and the presence of wheezing, I would next conduct a focused respiratory assessment, carefully auscultating the lungs to pinpoint the location and severity of the wheezing. I would also be alert for other abnormal breath sounds, such as crackles or diminished breath sounds, which could suggest more complex respiratory issues. Simultaneously, I would check the patient's oxygen saturation using a pulse oximeter to understand their oxygenation status. To gain further insight, I would ask the patient about any recent events or triggers that may have worsened their asthma symptoms. It is important to understand their usual asthma management routine and whether they had recently used any medications, such as inhalers or nebulizers. Reviewing the patient's medical record for an asthma action plan would also provide guidance on the best course of treatment during an exacerbation. In terms of immediate intervention, I would begin by administering supplemental oxygen to counteract any hypoxia. Depending on the severity of the patient's symptoms, I would choose between a nasal cannula or a face mask for oxygen delivery. I would then assist the patient in using a bronchodilator inhaler, such as albuterol, which helps relieve bronchoconstriction. If the patient was in too much distress to use the inhaler effectively, I would prepare and administer a nebulized bronchodilator to ensure proper medication delivery. Throughout this process, I would closely monitor the patient's response, checking for signs of improvement in breathing, reduced wheezing, and better oxygen saturation. If the patient's condition did not improve or worsen despite these interventions, I would escalate care by alerting a rapid response team or notifying the attending physician. These steps would ensure the patient receives the necessary advanced medical treatments, which may include intravenous medications or other urgent interventions. Once the patient is stabilized, meticulous documentation is essential. I would chart every detail of the situation, starting from the patient's initial complaint of shortness of breath, to the findings from my assessment, including wheezing, respiratory rate, and oxygen saturation levels, and all the interventions provided, such as oxygen therapy and bronchodilator administration. I would also document the patient's response to the treatment, noting whether their symptoms improved or deteriorated. Additionally, I would include any communications with the patient regarding their asthma management plan and consultations with other healthcare providers. This detailed documentation serves multiple purposes. It ensures that the entire healthcare team is informed about the patient's condition and the care they received, enabling seamless continuity of care. Moreover, thorough charting provides a legal record of the clinical decisions made and the treatments performed during this episode of respiratory distress. In conclusion, managing a patient with asthma who is experiencing shortness of breath requires a structured approach that prioritizes rapid assessment and intervention. By addressing the patient's immediate needs, closely monitoring their response, and maintaining clear documentation, I would help ensure the best possible outcomes in such a critical situation.
If you are a nurse on a unit and you have a patient who is asking for pain meds, a patient who is leaving for the OR, and the OR doc calls and says they are coming up in 5 minutes and you need to have the patient ready, a patient who needs to use the restroom, a patient who feels sick and a patient who wants someone to sit with them, who do you see first and why?
As a nurse faced with multiple simultaneous demands, it is crucial to prioritize patient care based on the urgency of each situation. In this scenario, I would first assess the level of urgency and potential risks associated with each patient's needs. The patient who is preparing to leave for the OR is the highest priority because timely preparation is essential for the surgical schedule, and any delay can disrupt not only this patient's procedure but also the entire OR schedule. Ensuring that the patient is ready involves verifying that they have followed preoperative instructions, completing any final pre-op checks, and making sure that all necessary documentation is in order. Additionally, the patient must be physically and emotionally prepared for surgery, which includes addressing any last-minute concerns or questions. Next, I would address the patient who feels sick. This could indicate a range of issues from mild discomfort to something more serious that requires immediate attention. Assessing the severity of their symptoms and providing appropriate care or interventions is important to ensure their condition does not worsen. After stabilizing the patient who feels sick, I would prioritize the patient requesting pain medication. Effective pain management is crucial for patient comfort and can prevent the escalation of pain, which can negatively impact their overall recovery and well-being. Quickly administering pain relief can also improve the patient's ability to participate in other necessary care activities. Following that, I would attend to the patient who needs to use the restroom. Addressing this need promptly is important for the patient's comfort and dignity. Prolonged waiting can lead to physical discomfort and potential issues such as urinary retention or incontinence, which can further complicate their medical condition. Lastly, I would attend to the patient who wants someone to sit with them. While emotional support is important for patient morale and mental health, it is not as immediately critical as the other needs. However, I would ensure that the patient knows they are not being ignored and that I or another staff member will be with them as soon as possible. In the interim, I might ask a colleague or a volunteer to provide some companionship until I can attend to them personally. In summary, I would see the patient who is preparing for surgery first due to the strict timing and potential complications of delaying their procedure. Next, I would attend to the patient who feels sick to ensure their condition is not serious. Then, I would provide pain medication to the patient in pain to prevent their condition from worsening. I would follow this by assisting the patient who needs to use the restroom to maintain their comfort and dignity. Finally, I would provide emotional support to the patient who wants someone to sit with them, ensuring they feel cared for and supported. This approach prioritizes patient safety, comfort, and the efficient functioning of the unit.
If you have a diabetic patient who is not communicative, what do you do?
If I have a diabetic patient who is not communicative, my primary concern would be to assess and address any immediate medical issues that could be causing their non-communicative state. The first step is to evaluate their level of consciousness. I would check if the patient is responsive to verbal or physical stimuli, such as calling their name or gently shaking their shoulder. If the patient does not respond, this could indicate a serious underlying condition that needs urgent attention. Next, I would assess the patient's vital signs, including blood pressure, heart rate, respiratory rate, and oxygen saturation. Monitoring these parameters can provide clues about the patient's overall condition and help identify any immediate threats to their health. Given the patient's diabetic status, it is crucial to measure their blood glucose level promptly. Hypoglycemia, low blood sugar, is a common and potentially life-threatening condition in diabetic patients that can lead to altered mental status or unresponsiveness. If the blood glucose level is found to be low, I would administer a quick source of glucose, such as glucose tablets or a glucose gel, if the patient can safely swallow. If the patient is unable to swallow, I would follow protocol for administering intravenous glucose or glucagon, depending on the severity of the hypoglycemia and the resources available. Conversely, hyperglycemia, high blood sugar, can also cause changes in mental status and must be addressed. If the blood glucose level is excessively high, I would inform the attending physician or diabetes care team immediately to get orders for appropriate interventions, such as insulin administration and hydration. While addressing the blood glucose levels, I would also assess for other potential causes of non-communication, such as infection, stroke, or other metabolic imbalances. A thorough physical examination is necessary to identify any signs of infection, such as fever, redness, swelling, or discharge, which might indicate a need for antibiotics or other treatments. Throughout this process, I would maintain close communication with the healthcare team, including notifying the attending physician and possibly calling a rapid response team if the patient's condition appears critical. Continuous monitoring of the patient's vital signs and responsiveness is essential to detect any changes that might require further intervention. Additionally, I would review the patient's medical history and current medication regimen to identify any recent changes or potential side effects that could contribute to their current state. Consulting with family members or caregivers, if available, can also provide valuable information about the patient's baseline behavior and any recent concerns or changes they may have noticed. Finally, I would ensure that all interventions and observations are meticulously documented in the patient's medical record. This includes recording the initial assessment findings, blood glucose levels, interventions performed, the patient's response to these interventions, and any communications with the healthcare team. Accurate documentation is crucial for continuity of care and provides a detailed account of the patient's condition and the care provided. In summary, addressing a non-communicative diabetic patient involves a systematic assessment of their level of consciousness, vital signs, and blood glucose levels, followed by appropriate interventions to manage hypoglycemia or hyperglycemia, and continuous monitoring and documentation to ensure comprehensive care and patient safety.
If you are a nurse on a floor and one patient is experiencing a transfusion reaction, another patient is in shock, and a third patient with low blood pressure, who do you see first and why?
If I am a nurse on a floor with one patient experiencing a transfusion reaction, another patient in shock, and a third patient with low blood pressure, I need to prioritize care based on the severity and immediacy of each condition. The first patient I would attend to is the one experiencing a transfusion reaction. Transfusion reactions can rapidly become life-threatening and require immediate intervention to prevent severe complications or death. Symptoms of a transfusion reaction can include fever, chills, itching, rash, shortness of breath, hypotension, or hemolysis. The most urgent steps would be to stop the transfusion immediately, maintain intravenous access with normal saline to keep the vein open, and call for assistance from other healthcare providers. Monitoring the patient's vital signs, providing oxygen if needed, and preparing to administer medications such as antihistamines, corticosteroids, or epinephrine, depending on the type of reaction, are crucial steps. The prompt cessation of the transfusion and supportive care can prevent the progression to more severe symptoms such as anaphylaxis or acute hemolytic reactions. Next, I would attend to the patient in shock. Shock is a critical condition that indicates inadequate blood flow to organs and tissues, which can rapidly lead to organ failure and death if not treated promptly. Symptoms of shock can include hypotension, tachycardia, altered mental status, cold and clammy skin, and decreased urine output. The priority in managing shock is to identify and treat the underlying cause, whether it is hypovolemic, cardiogenic, distributive, or obstructive shock. Immediate interventions would include ensuring adequate airway and breathing, providing oxygen, establishing intravenous access, and administering fluids or medications as appropriate. If the patient is hypovolemic, rapid fluid resuscitation with crystalloids or blood products may be necessary. If the cause is cardiogenic, medications to support heart function might be required. The goal is to stabilize the patient's hemodynamic status and improve tissue perfusion. Finally, I would attend to the patient with low blood pressure. While hypotension can be a sign of a serious underlying condition, it is not immediately as critical as a transfusion reaction or shock unless accompanied by symptoms such as altered mental status, chest pain, or severe weakness. The first step in managing a patient with low blood pressure is to assess their overall clinical status and look for potential causes. This involves taking a detailed history, performing a physical examination, and possibly ordering diagnostic tests. Interventions may include administering fluids to increase blood volume, adjusting medications that may be contributing to low blood pressure, or other treatments based on the underlying cause. Monitoring the patient's vital signs closely to detect any changes that might indicate a worsening condition is also important. In summary, I would prioritize seeing the patient with the transfusion reaction first due to the immediate risk of severe complications or death if not addressed promptly. I would then attend to the patient in shock, as shock represents a life-threatening condition requiring rapid intervention to prevent organ failure. Lastly, I would see the patient with low blood pressure, ensuring that while their condition is managed appropriately, they are continuously monitored for any signs of deterioration. This approach ensures that the most life-threatening conditions are addressed first, optimizing patient outcomes and maintaining patient safety.
If you have an older patient that has been in bed for 2 weeks, is short of breath, and has a respiratory rate of 40, what do you do?
When dealing with an older patient who has been bedridden for 2 weeks, is short of breath, and has a respiratory rate of 40, my immediate priority is to assess and stabilize their respiratory status. A respiratory rate of 40 breaths per minute is significantly elevated and suggests severe respiratory distress, requiring prompt intervention. First, I would quickly assess the patient's airway, breathing, and circulation, ABCs. Ensuring the airway is clear is essential. I would look for any signs of airway obstruction and listen for abnormal breath sounds, such as wheezing, crackles, or diminished breath sounds, which can indicate different underlying issues like bronchospasm, fluid in the lungs, or pneumonia. Observing the patient's overall appearance, I would look for signs of cyanosis, bluish discoloration of the lips or skin, use of accessory muscles, and any evidence of increased work of breathing. Given the patient's symptoms and history of being bedridden, I would suspect possible complications such as pneumonia, pulmonary embolism, or exacerbation of a chronic respiratory condition like COPD. To gather more information, I would quickly measure the patient's oxygen saturation using a pulse oximeter. If the oxygen saturation is low, supplemental oxygen would be administered immediately to improve oxygenation. The method and amount of oxygen delivered would depend on the severity of the hypoxia and the equipment available, ranging from a nasal cannula to a non-rebreather mask for more severe cases. Simultaneously, I would ensure the patient is in a comfortable and optimal position to ease breathing, typically sitting upright if they can tolerate it. This position helps expand the lungs and improve ventilation. While providing these immediate interventions, I would notify the attending physician or the rapid response team to get additional support and further medical evaluation. Describing the patient's condition accurately, including their respiratory rate, oxygen saturation, and any other relevant symptoms or history, would be crucial for the medical team to understand the urgency of the situation. Additionally, I would prepare for potential diagnostic tests as ordered by the physician. These might include a chest X-ray to look for pneumonia or other lung conditions, blood tests such as arterial blood gases to assess the severity of the respiratory distress, and possibly a D-dimer test if a pulmonary embolism is suspected. Monitoring the patient continuously is vital to detect any changes in their condition. This involves regular checks of their respiratory rate, oxygen saturation, heart rate, and overall appearance. If the patient's condition deteriorates despite initial interventions, I would be prepared to escalate care, which could include advanced airway management or transferring the patient to a higher level of care such as the intensive care unit, ICU. Throughout this process, I would ensure all interventions and observations are meticulously documented in the patient's medical record. This includes the initial assessment, oxygen administration, the patient's response to interventions, communications with the healthcare team, and any orders received and carried out. Comprehensive documentation is essential for continuity of care and provides a clear record of the patient's clinical status and the care provided. In summary, managing an older patient with significant respiratory distress involves rapid assessment and stabilization of their respiratory status, immediate interventions to improve oxygenation, continuous monitoring, and prompt communication with the healthcare team to ensure timely and appropriate medical management. This approach aims to stabilize the patient's condition and prevent further deterioration, ensuring the best possible outcome.
If you are a nurse on a floor and the ventilator alarm is sounding and the high-pressure alarm is sounding, what do you do?
If I am a nurse on a floor and the ventilator alarm is sounding, specifically the high-pressure alarm, my immediate priority is to assess and address the cause of the alarm to ensure the patient's safety and adequate ventilation. First, I would quickly go to the patient's bedside to assess their overall condition. I would check for signs of distress, such as agitation, cyanosis, or increased work of breathing. These signs can indicate that the patient is not receiving adequate ventilation, which requires prompt intervention. Next, I would examine the ventilator settings and the circuit for any obvious issues. The high-pressure alarm typically indicates that there is increased resistance to airflow or decreased compliance in the patient's lungs. Common causes include obstructions in the airway, such as mucus plugs, kinks in the ventilator tubing, or the patient biting the endotracheal tube. I would look for these potential obstructions and correct them if found. For instance, I would ensure that the tubing is not kinked and that the patient's head and neck are positioned properly to facilitate airflow. I would then listen to the patient's breath sounds using a stethoscope to identify any abnormalities such as wheezing, crackles, or absent breath sounds. Wheezing might suggest bronchospasm, while crackles could indicate fluid in the lungs. Absent breath sounds on one side might indicate a pneumothorax, which requires immediate medical attention. If the issue is not immediately apparent or easily corrected, I would manually ventilate the patient using a bag valve mask, BVM, to ensure they receive adequate oxygenation and ventilation while investigating further. Manual ventilation allows me to feel the resistance and confirm whether the issue is related to the ventilator or the patient's airway/lungs. Simultaneously, I would call for help from respiratory therapists and the attending physician to assist in diagnosing and resolving the problem. Describing the patient's condition and the steps I have already taken will help the team understand the urgency and nature of the situation. Continuously monitoring the patient's vital signs, including oxygen saturation, heart rate, and blood pressure, is crucial to detect any signs of deterioration. If the patient's condition worsens, I would be prepared to take further action, such as increasing the oxygen concentration or administering medications as ordered by the physician. Throughout the process, I would ensure that all interventions and observations are meticulously documented in the patient's medical record. This includes the initial assessment, actions taken to address the high-pressure alarm, the patient's response to these actions, and any communications with the healthcare team. In summary, addressing a ventilator high-pressure alarm involves quickly assessing the patient's condition, checking for obstructions or issues with the ventilator circuit, manually ventilating the patient if necessary, calling for additional support, continuously monitoring the patient's vital signs, and thoroughly documenting all actions and observations. This approach ensures the patient receives timely and effective care, preventing complications and maintaining their respiratory function.